my own silhouette. I'm getting stronger, step by step. The clock is ticking, but there's no time for regrets. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. We are heroes tonight. We will fly above the sky. We are heroes tonight. Yeah. We are heroes tonight. We will fly above the sky. We are heroes tonight. Feel like a dynamite, ready to explode right up in the sky. I need you to listen, I need you to hear, and don't show any fear. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. We are heroes tonight. We will fly above the sky. We are heroes tonight. Yeah. We are heroes tonight. We will fly above the sky. We are heroes tonight. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. close till I get up. Time is barely on our side. I don't wanna waste what's left. The storms we chase are leading us, and love is all we'll ever trust. Yeah, no, I don't wanna waste what's left. And on we'll go, through the wastelands, through the highways, till my shadow turns to sun rays. And on we'll go, through the wastelands, through the highways, and on we'll go. a bit of fun till I downfall. My love, if you feel like I do right now, don't say you're on the run to the other side. My love, you say you wanna try, but you never do. Sugar, there's a reason why we lose. Feel the waves cut through me, hypnotized by the sounds I'm breathing in. Hold tight, chemicals collide. Hold tight, hold tight, hold tight. Dripping lights paint the skies, all because of you. Dripping lights paint the skies, only you can make me move. my own world of make-believe. Kids screaming in the cradles, profanities. I see the world through ice covered in ink and bleach. Cross out the ones who heard my cries and watched me weep. I love everything. Fire spreading all around my room. My world's so bright, it's hard to breathe, but that's alright. Hush. Take my eyes open to force reality. Why can't you just let me eat my weight in glee? I live inside my own world of make-believe. Kids screaming in their cradles, profanities. Some days I feel skinnier than all the other days. Sometimes I can't tell if my body belongs to me. I love everything. Fire spreading all around my room. My world's so bright, it's hard to breathe, but that's alright. Hush. Hold your breath and feel the tension. Devils hide behind redemption. Honesty is a one-way gate to hell. I wanna taste consumption. Breathe faster to waste oxygen. Hear the children sing aloud. It's music till the wick burns out. Be carefree lately, yeah. Just picking up daisies. Got one too many quarters in my pockets. Counting like the 4-leaf clovers in my locket. Untied laces, yeah. Just tripping on daydreams. Got dirty little lullabies playing on repeat. Might as well just ride around the nursery and count sheep.
does perfect even mean? Is there even such a thing? Ooh, can we switch up all the rules and imagine a utopia? Darling, I'm just so fed up with these expectations. They keep weighing me down. My heart is begging me to get the hell out of my head. I'm gonna live inside the upside down for a minute and pretend, honey, I'm a perfect 10. Whoa, whoa, honey, I'm a perfect 10. Whoa, whoa, and if I say it enough, it gets ingrained in my head, and I start to see, honey, I'm a perfect 10. Honey, I'm a perfect 10. Whoa, honey, I'm a perfect 10. Honey, I'm a, yeah. Yeah, I've discussed it with myself, and I'm disgusted with the way we're told to have a certain face, a certain weight, because we aren't pixels on a screen. No, we're human, we breathe. Every single thing we see curated, it's overrated. These expectations, they keep weighing me down. My heart is begging me to get the hell out of my head. I'm gonna live inside the upside down for a minute and pretend, honey, I'm a perfect 10. Whoa, honey, I'm a perfect 10. Whoa, and if I say it enough, it gets ingrained in my head, and I start to think, honey, I'm a perfect 10. Honey, I'm a perfect 10. Whoa, honey, I'm a perfect 10. Honey, I'm a, yeah. Oh, 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 oh. Staying up when I go out, you gotta know I'm all yours. But when I say what's that about, you start slurring your words. Tell me why you have to seem so distant when I'm holding you. Your fingertips are drifting away, and I fucking love how it hurts. Why do I, baby, why do I love the way you always leave me? Why do I, baby, why do I love the touch but never love the feeling? Why do I, baby, why do I love the way you always leave me? Why do I, baby, why do I love the touch but never love the feeling? Why do I, baby, why do I? Why do I, baby, why do I? Why do I, baby, why do I love the touch but never love the feeling?
Why do I feel like I linger? Linger between the words to say the words to remember. Now we're here to take control over your body and over your soul. We're gonna take back everything and lose it all. Lose it all. We lose it all. Feel it in your arms, feel it in your legs, feel it on your fingertips and feel it in your head. Just let your body go, just let your body go, just let your body go and move to the rhythm. Now we won't go back home today, until the very last hour. We still got few more days to slay, it's gonna get so much louder. Now we're here to take control over your body and over your soul. We're gonna take back everything and lose it all. Lose it all, lose it all. Feel it in your arms, feel it in your legs, feel it on your fingertips and feel it in your head. Just let your body go, just let your body go, just let your body go and move to the rhythm. like I linger, linger between the words you say, to say the words you remember.
Yeah.
Over the edge, feel like I'm floating through the air. The pain I felt is paid for, all is said and done. Oh, I am restricted, fixed upon the web. I need to kick the habit that my mind is breathing in. Break out, I've got to see. Spent all my life holding all of it closely. I played it innocent, a feel of discontent. I'm finally facing it all, fearless. Burning the bridge that keeps us. I'm here and I'm feeling fearless. Exaggerated, that's what you assume. The story's over now, I must conclude. I am conflicted, watching where I step still, hanging in the balance. Not the life I want to live, I want to take it all. Standing tall, fear outweighed the person you are. Oh, break out, I've got to see. Spent all my life holding all of it closely. I played it innocent, a feel of discontent. I'm finally facing it all, fearless. Fearless.
the street lights lit this town like a fire in a blaze, gotta burn it down. Can't be afraid to leave this out. We got this far, don't know how. I see danger in your eyes. They know we'll burn down the night. Coming just like the sunrise. You know that we gonna let it rain. Tonight, we gonna let it rain. Tonight, we gonna let it rain. Just like the sunrise, we gonna let it rain. Just like a spark that's breaking out. Can't make a stop, can't turn back now. We know that there's no room for doubt. No, we can't turn back now. I see danger in your eyes. They know we'll burn down the night. Coming just like the sunrise. You know that we gonna let it rain. Tonight, we gonna let it rain. Tonight, we gonna let it rain. Just like the sunrise, we gonna let it rain.
Eyes in the sky, gazing far into the night. I raise my hand to the fire, but it's no use, 'cause you can't stop it from shining through. It's true, baby, let the light shine through. If you believe it's true, baby, won't you let the light shine through for you. gazing far into the night. I raise my hand to the fire, but it's no use, 'cause you can't stop it from shining through. It's true, baby, let the light.
Of Djamil Hospital in collaboration with Medical Faculty of Andalas University in celebration of the 71st anniversary of Djamil Hospital. My name is Yulia Oksiulanda and I'm excited to be your host today. Thank you for joining us. First of all, I would like to thank Professor Stephen M. Graham, MD, PhD. He is a professor of international child health from University of Melbourne, Department of Pediatrics. The Honorable Dr. Kino Cardiovascular Specialist Consultant, Representative Chief Executive Officer of Djamil Hospital, Professor Dr. Afriwardi, Sport Medicine Specialist, as a DN of the Faculty Medicine of Andalas University, Dr. Vini Fitriani, Pediatrician Respirology Consultant, as a Head of Pediatric Department of Djamil Hospital, and of course, Dr. Riki Alkamdani, Pediatrician, who plays role as a moderator in our webinar today. To begin our event, let us hear the opening speech from Dr. Vini Fitriani. The time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Yang terhormat Bapak Dekan Fakultas Kedokteran Universitas Andalas, yang terhormat Bapak Dirut Rumah Sakit Dr. M. Djamil Padang, and especially greeting for Prof. Steve M. Graham from University of Melbourne that come to our pediatric department to give the visiting lecture. Adapun pada siang hari ini kita akan mengadakan visiting lecture dari Prof. Steve Graham. Beliau adalah salah satu senior di bidang pediatrik respirologi anak, terutama dalam bidang penyakit-penyakit infeksi. Riset-riset beliau sangat banyak dan juga sebagai praktisi sejak muda di bidang kesehatan anak di Afrika dan sekarang berada di Melbourne. Beliau juga merupakan salah satu penggerak kegiatan TBC anak di tingkat global dan punya pengalaman banyak dalam hal penanganan dan manajemen tuberkulosis. Mudah-mudahan nanti kita bisa mendengarkan dan mendapatkan apa yang bisa kita ambil untuk praktis kita nanti di bidang penyakit respirologi anak, terutama untuk TBC dan pneumonia. Thank you for Prof. Steve that could come to our department and enjoy it. And my apologies for some of the services that not in the right place. Terima kasih banyak atas kehadiran Bapak Ibu semua. Mudah-mudahan nanti kita bisa mendengarkan dengan baik. And welcome to Aranza that accompanied Steve to our visit Padang. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. What a wonderful opening from Dr. Vini. Let's continue to hear some speech from Professor Dr. Afriwardi, Medical Sport Specialist, as a DN of Medical Faculty of Andalas University. For Dr. Afriwardi, the time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, kita bersyukur kepada Allah Subhanahu wa taala pada kesempatan sore ini. Alhamdulillah kita hadir bersama dalam rangka untuk mendengarkan kegiatan webinar. Kali ini webinar karena memang tidak semua hadir pada keadaan offline. The first, I want to say hello to Prof. Stephen and Graham, MD, PhD. Thank you. You come in our institution. I'm very sorry because I want to join you in the room now. Selanjutnya kepada Direktur Rumah Sakit Djamil Padang dan seluruh staf pengajar, kepada teman dan seluruh hadirin dan peserta webinar yang saya hormati. Baiklah, pada hari ini kita akan melaksanakan satu kegiatan yang diajang oleh Departemen Ilmu Kesehatan Anak dan bekerjasama dengan yang diajang sebetulnya dalam rangka untuk memperingati hari ulang tahun daripada Rumah Sakit Djamil Padang. Mudah-mudahan kontinuitas dan keberkahan itu akan didapat oleh seluruh hospitalia Rumah Sakit Djamil Padang. Amin amin amin. Baiklah, pada hari ini kegiatan yang diajang oleh Ilmu Kesehatan Anak itu mengambil topik yaitu Child Lung Health Update on the Pneumonia and Tuberculosis. Yang hari ini kita melihat dan menghadirkan selama sumber Prof. Stephen yang memiliki reputasi yang biasa menyampaikan kita dan mudah-mudahan pada hari ini kegiatan ini tentu hendaknya dapat kita manfaatkan kebetulan sebetulnya kemarin ini memberikan ke kita bahwasanya kita akan kajian tamu dan bisa kita manfaatkan untuk dilaksanakannya satu kuliah atau lecture visiting professor di tempat kita, dan ini lebih sangat menarik bahwasanya pemanfaatan dan penggunaan yang kita dapat pada hari ini itu insyaallah akan menjadikan kita akan terpapar oleh kegiatan-kegiatan dengan sumber-sumber keilmuan yang para ahli sehingga pada hari ini mudah-mudahan semua peserta nanti akan mendapatkan hasil ataupun output yang memadai dan mendapatkan keilmuan yang baru terupdate baik ini khusus untuk kesehatan paru ini. Kemudian tentu kami juga ingin menyampaikan kepada semua partisipan atau pada semua peserta dapat memanfaatkan momen yang sangat luar biasa ini untuk kita bisa menimba ilmu dari para ahlinya. Manfaatkan sebaik-baiknya, semoga kita akan mendapatkan hal-hal yang baru dan hal-hal yang terupdate berkaitan dengan penata-laksanaan kesehatan untuk mengupayakan sehat paru terutama untuk anak-anak pada hari ini. Akhirnya sebelum saya mulai penutup penyampaian pada hari ini, kami sekali lagi ucapkan selamat ulang tahun buat Djamil. Mudah-mudahan kita selalu diridai oleh Allah Subhanahu wa taala. Special thanks to Prof. Stephen and Graham, MD and PhD, you come to my institution. Thank you very much. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Afriwardi, for the welcoming speech. We continue our event. For Dr. Kino, cardiovascular specialist consultant, please give some speech about the event today. For Dr. Kino, the time is yours.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Yang kami hormati Bapak Dekan Fakultas Kedokteran Universitas Andalas, Prof. Priwadi, kemudian Ketua IDAI Cabang Sumatera Barat, Dr. Vini Fitriani, kemudian special guest from the Melbourne University, welcome Prof. Stephen M. Graham. Hopefully you enjoy in Padang, especially in Minangese food. You should try some special food from Minang, such as rendang and kerupuk jengkol. Kemudian Bapak Ibu hadirin yang hadir pada siang hari ini, baik secara langsung maupun secara tidak langsung via Zoom. Puji syukur hanya Allah Subhanahu wa Ta'ala, kita bisa berkumpul bersama pada media yang ada saat ini untuk mengikuti kegiatan International Webinar Update for Child Lung Health yang akan disampaikan oleh special guest from the Melbourne University, Prof. Stephen M. Graham and Dr. Vini Fitriani. Mudah-mudahan kegiatan pada hari ini yang merupakan juga rangkaian kegiatan HUT HKN dan HUT Djamil. Mudah-mudahan serial webinar ini bisa menambah pengetahuan kita, bisa menambah some knowledge to us about the lung disease in children, especially in tuberculosis maybe ya. Mudah-mudahan kegiatan hari ini bisa memberikan banyak manfaat, terutama bagi Rumah Sakit Djamil Padang, bagi Departemen KSM Ilmu Kesehatan Anak, bagi teman-teman PPDS, bagi kita semua, sehingga nanti diagnosis dan penanganan penyakit paru pada anak ini bisa kita update, bisa kita aplikasikan. Mudah-mudahan nanti insya Allah rumah sakit juga akan mensupport adanya pemeriksaan terbaru, adanya obat-obat terbaru untuk proses pelayanan dan pendidikan yang berlangsung di RSUP Djamil Padang dan Departemen Ilmu Kesehatan Anak FK UNAND. Sebagai penutup, mudah-mudahan acara ini berjalan sukses and Prof. Stephen M. Graham can enjoy with our lecture this afternoon. Lebih dan kurang mohon maaf. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Kino, for the speech. Now, it's my pleasure to introduce our moderator, Dr. Ricky Alkamdani, pediatrician. Before inviting him, I would like to present his curriculum vitae. Take a picture first. For all of the presenters, Dr. Kino, Dr. Afriwardi, please turn off the camera. And all of online
I already have turned off my camera.
It's already on, sir. And all of the participants in Zoom, please turn on the camera. Let's take the picture. Second slide. The third slide. Fourth slide. And the last slide. Okay, it has been captured. Thank you. And now it's my time to present Dr. Ricky. For Dr. Afriwardi and Dr. Kino, if you have another schedule, please to leave this meeting.
No.
I have
will
another
stay
agenda
here.
to adaptan from the Jakarta, Dr. Spesialis Anak. I should meet the other agenda. Thank you, Prof. Thank you, Dr. Vini.
Joining us, sir.
But I stay here. I have to hear from Prof. Stephen.
Okay, let me introduce our moderator today, Dr. Ricky Alkamdani, pediatrician. Please show the curriculum vitae. Dr. Ricky Alkamdani, pediatrician graduate medical doctor from Andalas University 2010, pediatrician from University of Indonesia 2007, pediatric respirology consultant trainee, current, and his current position, academic staff, Department of Child Health, Faculty of Medicine, University of Andalas, Djamil Hospital, and also a member of Indonesian Pediatric Respirology Society, Indonesian Pediatric Society. And now let's begin our discussion. Please, Dr. Ricky Alkamdani, Pediatrics, joining us. Thank you.
Okay, thank you. Welcome to International Webinar Update for Child Lung Health, celebrating 71st anniversary of Hospital Djamil Hospital, organized by Child Health Department, University of Andalas, Djamil Hospital. My name is Ricky and I'm your moderator today. Maybe we proceed to the first speaker. Our first speaker is please the CV. Our first speaker is our Wonder Woman, Dr. Vini Fitriani, spesialis anak consultant. She is a medical doctor from Universitas Andalas. The first speaker, yes. Current position is this is the head of Child Health Department. Please, Dr. Vini, your talk.
Thank you, Dr. Ricky. My greeting for Prof. Steve and Aranza. Thank you for coming to visit us. I just want to present about 10 minutes, maybe. I want to share about our condition in pediatric department Djamil Hospital, special for respirology health services, pediatric respirology health services. Ini nih. Yeah. This is our pediatric department location in Dr. Djamil Hospital. Dr. Djamil Hospital is the third hospital that location in the West Sumatra. You know, Sumatra is the big island part. West part in Sumatra is the Padang, the big city of the West Sumatra. Yes, let's so. And the Djamil Hospital service not only the West Sumatra province population, but also receive the referral patient from the around province around the West Sumatra, like the Bengkulu in the south part, Jambi in the west east part, yeah, yeah, yeah. So we know that since years 1950, Dr. Djamil Hospital has established to serve the population. And Dr. Djamil Hospital also as the teaching hospital, the main teaching hospital for produce many general practitioner like in the back. Every years we can produce about 100 new general practitioner, and Djamil Hospital also produce many specialists, pediatrician, neurologist, surgeon, internist, and others. And this is the history of Djamil Hospital. Until this time, Djamil Hospital have the vision to leading healthcare excellence in Southeast Asia through exceptional service, education, and research. Slide. And how about our department, pediatric department? This is the second place of our pediatric department. The first place in the back part of this hospital, and in this place we stay since 10 years ago. Our department established since 1964, and developed pediatric residency training specialist program since 1991, and already produced 175 pediatricians. Also, now we have the student of pediatric residency about 71. Not all in this room now because they have many duty in the pediatric outpatient, pediatric ward, and other. And we have the pediatric staff, 24 staff with 13 pediatric division. Right? And this is our vision of Department of Child Health, become a leading pediatrician education provider and produce during disaster, like the breastfeed education for breastfeed, to make the food to food safety for children and others. Yes. Okay, slide. And this is our pediatric service facilities in our room. You know that in the morning you already visit our facility and visit our patient. And this is the all of our facilities, right? And especially for pediatric respiratory services facility, we have limited human resources that multitasking, and I hope Dr. Ricky will join as consultant after in the next few months. And the facilities have several facilities, but unfortunately, special for bronchoscopy, we only join with the adult equipment. But you say that not only patient has to do the bronchoscopy, yes, right? So I think that in many conditions we should consider some of this activity. And we have the spirometry also, and the procedure in pediatric respiratory services about the tuberculin skin test, sputum induction, spirometry, pleural function, mini WSD, and others. Also non-invasive ventilation at home, but not all of the procedure is established well. So, slide. This is a pediatric respiratory squad. Not only two, but we have our lead teacher, Prof. Dr. Darvius Basir, special consultant that passed away 2 years ago. And this, you look at Prof. Darvius familiar with Simon's cuff. You know that? Yes, do you remember? Yeah, Simon is very similar with Prof. Darvius. Yes. And this is me, it is Dr. Ricky, and maybe in the next future we can recruit the new pediatrician to complete our squad. Slide. And this is the top 10 of hospitalized diseases at pediatric ward during 2020 and 23. Bronchopneumonia with the complicated condition is the most our patient, and then meningitis, renal failure, post-laparotomy, and other. This is for the whole of pediatric ward. Slide. And for the 5 hospitalized of respiratory diseases at pediatric ward is the bronchopneumonia with the comorbid condition, laryngomalacia, and lung tuberculosis, and comorbid with TB meningitis, and chronic respiratory symptom due to the several conditions like the cerebral palsy and others, and also pneumonia aspiration. Slide. And top 5 of hospitalized of respiratory diseases at pediatric outpatient. I'm sorry, I mean the pediatric outpatient. Lung TB, visit 1 year, about 600. Lung TB and meningitis TB, post pneumonia, TB lymphadenitis, and asthma. Slide. We not only work in hospital, but we also work out of the hospital. We have many rules as the key opinion leader, like as the Copy TB, you know that maybe Copy TB Coalition of Organization Professional, trainer for pediatric TB program in West Sumatra, and trainer for pneumonia, develop guidelines, national guidelines, and others tasks. Because I think that we not only do the patient by patient only one, but we should expand our role into the community, because we should active in promote and preventive too, to improve the competence of our health worker in the out of the hospital. Slide. So our future direction of pediatric respiratory services, we should recruit one until 2 new staff. I have a dream to send my junior to PhD student to abroad, maybe to Melbourne, I don't know. And now we apply new equipment for pediatric bronchoscopy for Dr. Ricky, and develop non-invasive procedure, and we propose to a new develop pediatric respiratory consultant training, like in Jogja. Maybe we have new ARUF in here from near of our province. Slide. This is one case of my case that I taught you already, that the adolescent with tuberculosis drug resistant that have the delayed diagnosis of the RTB. Why? Because in the initial phase of the diagnosis, the patient didn't do the sputum expert. So the patient only treat by the sensitive drug regimen. Unfortunately, by month the condition worsening, and then she was diagnosed by the DRTB, and then we treat the DRTB. Sadly, the condition of the lung is destroyed. So the destroyed lung, you know, that can cause the cor pulmonale chronic, cor pulmonale. So finally, she passed away caused by the cardiac failure. Right? But I have the patient that make us happy, that the patient with biliary TB and hydrocephalus, but come with in the initial phase. So we as soon possible use the VP something, and after that he wake up, and 2 months later he can loncat apa sih, jump, yeah, walk well and jump like a normal children. So this case make me happy. This is the, as we can see in the data, that the contact TB for the child is the father, was the father. And when the health worker from Puskesmas came to the house, the patient in condition in morbidly, and after the morbidly finish, resolve, the body weight not increase but worsening by the time. And then he came to our emergency hospital with the seizure, and in the brain CT scan we found the hydrocephalus, and then acute hydrocephalus, and then pasang apa? Yes, got the 50 star. Yes, Dr. Rahmi Lestari is our neuropath. Yes, so we always work closely for this patient like this. So this is very, very make me sad. What initially, because the parent are the healthcare worker, but finally this patient make us happy. Slide. So many challenges that we face in our pediatric respiratory rare services, but some of challenges cannot resolve immediately, but by the time we will improve our services, and by the time I will develop some education, some special education maybe, and other. So is it maybe one of our prestigious event to have you come to our department. Yeah, slide. Thank you for the time, and thank you for your coming. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dovy. That's amazing job despite of enormous challenges that you are facing. She kept trying, she kept improving and inspire everyone, especially younger generations. We believe by collaborating, we can conquer all the challenges and find and make a contribution to our children in West Sumatra, also in Indonesia. Next, we move to our distinguished speaker, Prof. Steve Graham is a pediatrician with interest in infectious disease and respiratory health, who is based at the Royal Children's Hospital in Melbourne, Australia. He is professor of international child health with the University of Melbourne and co-lead of Melbourne Children's Global Health. He is also a senior technical advisor with the Union on Child and Adolescent Tuberculosis and Lung Health with the Burnet Institute. Steve has many years. CV, please. Steve has many years of clinical research and teaching experience in child and adolescent health in the African and Asia Pacific regions. His PhD focus was on respiratory disease in children with HIV in Malawi. Steve is a founding co-member in 2003 and previous chair of the WHO Stop TB Partnerships Child and Adolescent TB Working Group. His recent research interest in implementing and evaluating integrated strategies to detect, treat, and prevent tuberculosis, including drug-resistant tuberculosis. So, Prof. Steve, please.
Thank you very much. Terima kasih, Ricky. It's a great pleasure, great honor to be here at Dr. Djamil Padang Hospital, to be with the Universitas Andalas. I thank Dr. Afrawadi, Dr. Kina, Dr. Finney, Dr. Ricky for the warm welcome, and thanks to you all for attending. So I'm waiting for the slides. The focus of my talk, I think Dr. Finney has set it up very nicely, because I noted that in the, thank you, in the presentation of what are the common problems in the outpatients, what are the common problems in the inpatients, pneumonia and tuberculosis are definitely very, very prominent. I will not really be talking so much to the complicated cases. I've been, next slide, thanks. I've been spending time, do you want me to do the slides? Yeah. It might be easier if I do them, yeah? Where do I do them? Just takes time, okay. So, yeah, I mean, I've spent some time now in Indonesia on this particular trip, seeing patients in Dr. Sarjito Hospital in Surabaya, and now here this morning. And as is typical of a specialist hospital, you see a lot of quite complicated cases, yeah, and children with respiratory disease, but often on the background of some comorbidities, congenital heart disease, neurological problems, syndromes, developmental problems, oncology, etc. So, what I'm wanting to talk about is the importance of data for the common problems that we might see even outside of this hospital, and the critical issues around improving our clinical case management, and also the opportunities for prevention. Because I'm a very firm believer, having worked in resource-rich and resource-poor settings for all issues to do with lung health, we can always achieve a hell of a lot by just focusing on doing the basics very well. And often it's very nice to have all the increased resources, but we can still achieve a hell of a lot by doing, the basics well. So I don't need to remind you all that the commonest cause of illness and death in children is lung disease, and pneumonia is the major cause of under 5 mortality globally. And most of the causes are infections that can be prevented and treated. But I think we're just also starting to realize, and I'll show you some evidence, that having severe lung health as a child has lifelong consequences, which helps us focus more on improving management, but also how we can prevent severe disease in the first place. Because I have a particular bias towards tuberculosis, and because I recognize that Indonesia has a lot of challenges with tuberculosis, it has the second highest burden globally. Sorry, can I can see the slides, but it'd be then shall I meditate? Yeah. I'm thinking of the people who are also Just the next slide when you're ready. Yeah, so the tuberculosis is a major cause of maternal and child mortality and morbidity globally. And amongst adolescents, the commonest causes of morbidity and mortality due to infections are actually tuberculosis as well, with HIV. And I want to focus a little bit on that. Also, from a point of view of lung health, we know from studies from many settings in the world that there is a rising prevalence of asthma, including in low and middle income countries, particularly in children who live in urban settings. And though the mortality for asthma is generally quite low, the highest mortality for asthma occurs in the poorest communities because of their lack of access to preventers, etc. Next slide, thanks. So if you can look at these pie charts, things are changing, things are improving. When I was first involved in pediatrics in resource-limited settings, the contribution of lower respiratory tract infections to death in children under 5 was about 30%, and it's come down quite considerably. It's now thought to be around 15%, and then there's other tuberculosis, there's measles. And probably the main reason why there's been a reduction has been vaccines. It's been the ability of vaccines to be able to prevent some of the severe causes of pneumonia in children. And I just wanted you to focus, we don't usually have as much data on older children and adolescents, but you can see that lower respiratory tract infections, tuberculosis, etc., are common in that group as well. Next slide. So one of the reasons why it's important, I think, is that if you have severe lung disease as a child, we are starting to understand more and more that it actually has lifelong consequences. As we're doing studies now in adulthood of comparing children who had severe disease to children who didn't have pneumonia, as they're having their longitudinal cohort studies of following children from birth or adolescence to older age, we recognize that if you have problems when you're young, so that's the red line, then as your lungs mature, you are not going to get to the same level of lung function when you should be peaking as a young adult. And then as your lung function declines, which is normal with adulthood, you're going to decline also. And so by the time you get to older age, you're more likely to have symptoms and deaths due to lung disease. I have personal experience with this because I had severe asthma when I was young for many years without treatment, and my lung function now is only about 2/3 normal. And so it is a problem that seems to carry on through life. Next slide. So one of the things that I've been trying to talk to at Dr. Sarjito Hospital and elsewhere is we can learn a lot from one patient. We can learn a lot from N=1. And every time we look after a very sick child, we should be thinking beyond the bedside and beyond the immediate care that we can provide now. We have to ask ourselves, why is this child sick in the first place? Is there anything that we could have done to improve prevention so that this child never turned up in the hospital? Is there anything that we could have done for earlier detection and treatment? So Dr. Finney's just presented a case of drug-resistant TB where the diagnosis was very much delayed and the adolescent died. And we understand that when we work in these specialist hospitals, we often don't understand very well what is the reality for the puskesmas, what is the reality for the secondary care setting. But we have to try and understand that. And it's great that people, medical students more and more now spend time in their community and actually spend time working at those levels of care to try and understand the limitations, but also the importance of referral patterns, but also perhaps the fact that you can actually do quite a lot at that level of care and not have to refer all the sick children to the big hospitals. And then finally, one bit of work that's been very much a focus of the group in Melbourne, particularly led by Trevor Duke, but others, has been improving quality of care. And that goes to what I was talking about before. Even without a lot of resources, if we do the basics well, the oxygen, the antibiotics, that make getting the diagnosis right, we can often make a big difference. Next slide, thanks. The other thing that I wanted to mention is, and this is the point of being a clinician, such as myself, who is now working in Malawi and Africa, where a new medical school was starting, so very much involved in teaching. I wasn't particularly interested in research. But I realized there that because we had such an overwhelming problem of lung disease, partly because we had a lot of children with HIV, that you had to at least measure what you were doing. You had to do some operational research and understand what were the causes of all of the sickness, what were the causes of the death. So as somebody who wasn't particularly interested in research, I started doing some research. And I think that is an important part of what we do, to try and measure and understand why the burden of illness that we have in our hospitals. The reason I'm just highlighting this is because we often work with a very vulnerable population. We are pediatricians, and children do not have a voice. They cannot tell their story, whether it's to the government, to the Ministry of Health, to the rest of the world, about what are our health problems. And that's one of our roles as pediatricians. So just to give you an example, we had 1 in 10 children being born at that hospital had HIV, and about 40% of them died in the first year of life. And most of them died with pneumonia. This is before antiretroviral therapy. And I could see as a clinician that we thought that pneumocystis carinii pneumonia was common. And so we did some studies and we found pneumocystis with fluorescent microscope, and we found it to be a very common cause of death. And we provided that research. But at the time, there was studies going on in Malawi. There were studies going on because of the data from adults where the common respiratory illnesses were tuberculosis and pneumococcal disease, but not pneumocystis. Everyone said there is no pneumocystis in Africa. And so we had to then publish the work and write opinion pieces to change practice, because people from the US and other places were doing studies of mother-to-child transmission, but they were not putting children on cotrimoxazole preventive treatment because they said pneumocystis is not a problem in Africa. So it was really the use of data for advocacy to show that actually this is a problem. People don't recognize that TB in children is a problem for Indonesia, but it is a problem. And we have to improve the data. And the only way we often can do that is through research and by working together through research. Next slide. So one of the things to understand, I think, which is an obvious thing to say, is that we won't improve our clinical management until we often understand what are the causes of the pneumonia. And we know that there is a long list of potential causes of pneumonia: bacteria, viruses, atypical pneumonia, TB, fungi, etc. So what are the common ones? And one thing that has changed in my lifetime is that the focus is now going from bacterial causes to viral causes. Viruses are the commonest cause of childhood pneumonia globally, not just in resource-rich, high-income settings, but everywhere globally. For example, it's really important to recognize that. And also, only recently we recognized that even in children with acute severe pneumonia, tuberculosis is actually a not uncommon cause, especially in those who are malnourished. And we actually have very, very little data on the causes of pneumonia in older children and adolescents. We have much more in under 5. Next slide. So the important things to recognize is that hypoxemia is an ongoing challenge for many settings. It can be difficult to detect clinically, but fortunately now we have oximetry, which can improve that. But oxygen therapy is commonly unavailable. And again, we need data, not just in a hospital like this that has oxygen systems, but there are many settings, I'm sure, in the Indonesian setting that don't have strong oxygen systems. And yet often the thing that will save the life of a child with pneumonia is oxygen. And this was all very highlighted during the COVID pandemic, when we recognized globally that a lot of people were dying, particularly in resource-limited settings, just from a lack of oxygen, including past colleagues of mine in Malawi, in Zimbabwe, and places such as that. So that is a massive issue. And our group in Melbourne, along with others in Africa and globally, are involved in this Lancet Global Health Commission, which will publish, I think, by the end of this year, a lot about the evaluation of resources required for improved oxygen. Next slide. Just to try and emphasize the fact that we can do a lot better using the resources we already have. This is one bit of data from our work we did in Malawi, where we implemented improving the case management of pneumonia at all 25 district hospitals in the country. At the time of implementation, the mortality for pneumonia was 15%. And then by implementing just standardized care of antibiotics, oxygen, we were able to reduce that fatality by about 1/3, down to around 8% across the board in most of those hospitals. Next slide. The other challenge we have in pneumonia management is appropriate use of antibiotics. And if I do a ward round here, it doesn't matter whether the child has, we don't really know whether it's viral or bacterial, but we will have the child on meropenem, or we'll have the child on ceftriaxone or ampicillin and gentamicin. We use broad spectrum antibiotics readily in a setting such as this. And I can understand this because the children who come in here usually have quite severe pneumonia. But at the Puskesmas level or at the district hospital level, there is also the use of a lot of antibiotics in children who don't need them. And we have to be better, I think, at deciding which children require antibiotics and which children don't. And at the moment, we tend to base it on the level of severity. But we had a PhD student, Dr. Nguyen from Da Nang in central Vietnam, and the focus of her PhD was on the case management of children admitted to hospital with pneumonia. Most of the children admitted with pneumonia did not actually fit the case definition of pneumonia. Most of them had upper respiratory tract infections, but almost all of them got antibiotics, broad spectrum antibiotics, sometimes up to 10 days in hospital. Very expensive, very unnecessary, but it was very, very hard to change the practice of the physicians in that particular context. When she did introduce a management algorithm, it reduced antibiotic usage, it improved treatment outcomes, and reduced time in hospital. But when she left that hospital and went to work elsewhere, the practice went back to usual. So I think we all understand that we have a massive challenge in terms of our antibiotic usage in childhood respiratory disease. And it's not a small issue. It's a hugely expensive issue for health systems and families. But the major challenge now is we are developing antibiotic resistance. This morning we, for example, were talking about a child who had Acinetobacter, I think it was, that is resistant to pretty much every antibiotic, including meropenem. So this is a really big challenge as well. Next slide. But improving prevention is what I guess I wanted to talk about, and we'll end up talking about on TB. And we've been very, very fortunate with the immunisation coverage that we've been able to get for these diseases, such as measles, pertussis, and diphtheria. Though we did see during the COVID pandemic, with the reduction of immunisation coverage, we saw the re-emergence of these diseases, including in Indonesia. And that reminds us of how important this immunisation coverage is. There's no doubt in my mind that one of the reasons why we have much lower mortality from child pneumonia than we used to have is because we rarely see measles or pertussis. I've been around long enough to have seen those conditions, and they are very, very associated with a very high mortality. Also now we have high coverage against the two common bacteria that cause pneumonia, pneumococcus and Haemophilus. And this, by improving the coverage, it doesn't just protect the young children, but it also protects against pneumonia and sepsis in old people as well. For BCG TB prevention, I'm going to talk a little bit more about that down the track, but all I wanted to say is that our targets for household contact screening and for TPT is extremely poor globally. And this is an area that we really have to work on. Even for under 5 children, less than half of children who should be on TPT as household contacts do receive it. There's the development of new vaccines, such as RSV, which is a common pathogen. And in Melbourne, there's a group who are developing vaccines for Group A strep. And obviously air quality is an area that we would also have to talk about in terms of preventing lung disease in children. Next slide. So now to move to more specific bacteria, pathogens such as RSV. Let's just focus on that for a moment. It is the commonest pathogen causing child pneumonia. And as I said, that's not just in Melbourne, Australia, that's also across wherever it's been studied. And the PERCH study looked at this in countries in Africa and Asia, including Bangladesh. And the PERCH study found that RSV, by doing nasopharyngeal aspirates and looking for viruses, but also looking for bacteria, also looking for TB, RSV was the commonest. And you can see there that it is responsible for about almost a third for all ages, but particularly common in infants is what we expect. And these are the percentages for severe or very severe pneumonia. Now, in Melbourne with RSV, we recognise it very readily. It causes bronchiolitis. The children mainly come in the winter from May, June, July. It has a seasonal peak, which it doesn't have in the equator. Most of them may require some oxygen, but they get better. The mortality is not high, but the mortality is actually higher in resource-limited settings, and that's partly because children in those settings have other risk factors, such as they're malnourished, which leads to increased risk of secondary bacterial infection. So you may get less wheeze with RSV in a tropical setting, but the mortality tends to be higher. Next. So there is now evidence from a vaccine, and this is evidence just that was recently published, and this study was done in the Gambia and South Africa. So it was done in settings where you have RSV known to be common, but also RSV associated with a high mortality. And when they vaccinated mothers in the last trimester or towards the end of pregnancy, 24 to 36 weeks gestation, they found a protective efficacy of 82% against severe RSV-associated disease in those mothers' infants when following up after birth. So this is the placebo group who's developing cumulative incidence of RSV, and this is the group where the mother had received vaccination. And so you can see now that this is very hopeful evidence, and this was considered quite safe for the mothers. So there's hopeful evidence that we may be able to reduce RSV in early infancy. Next slide. There was also another study that's been recently published. This work was done in the north of Spain. I had to put this in because my wife's from Spain. And so, but this work was done, what they did was they used a monoclonal antibody and they gave it to groups of infants prior to the winter in Spain. So prior to the usual RSV season, and compared it and just made the observation of what impact it had. Next slide. And so that it was introduced. This is a long-acting monoclonal antibody that you can inject to the child. And it was given just before the typical RSV season, which is September. So going into the Spanish winter, the north of Spain, given in September to 3 groups of infants with high coverage. Thank you. Given with 3 groups of infants with very high coverage, and they compared what happened from data before, so previous RSV seasons, not COVID time, but during previous RSV seasons, to see what impact it might have on RSV. And what they found was that the proportion of infants who received the intervention had a lot less hospitalizations for RSV compared to those that did not. So the effectiveness was about 82%. Next slide. And that effectiveness was against severe RSV-related respiratory tract infection requiring oxygen, against all hospitalizations due to pneumonia, against all-cause hospitalizations. So very, very effective, a reduction of around 90%. And you only needed to treat about 25 infants to avoid 1 hospitalization. So, and it was safe. And so the pediatrician who led this study made the comment to us, the pediatricians in the winter were sitting around thinking, where are all the cases? We're usually busy this time of year. Suddenly we're not. So the impact on the health system and on the workload of the pediatric staff was huge. Next slide. Chronic lung disease is not so common in children. We talk much more usually about acute lung disease. We know that it's a big problem for HIV, children and adolescents living with HIV, though that burden has been reduced since prevention of mother-to-child transmission and early antiretroviral therapy. But those children with HIV, living with HIV in adolescence, they do still have long-term challenges with respiratory function. They commonly develop restrictive lung disease or bronchiectasis. They commonly get treated for TB. They actually have an increased risk of TB and an increased risk of being treated for TB, and it has a major impact of quality of life. Unfortunately, we don't have a lot of interventions to help them. They generally have just a slow downward course, becoming respiratory cripples, and then dying sometimes as late adolescents, early adults. And so this is a challenge. Next slide. And this is just, I only put this in because Lisa Abimbo, her PhD focus was on this, and maybe Dr. Finney has met Lisa, but this is a photo from this week. She received her PhD at the University of Nairobi, but she did a lot of work on this particular area. Next slide. And you can see in the systematic review, and this is not just, this is mainly adults and adolescents. After you've had TB, and this is people who have been treated for TB and have been cured of TB and are supposedly better, you can see that many of them still have ongoing symptoms, and many of them still have ongoing abnormalities of their chest x-rays. So there is a problem of post-TB lung disease. And this is a major focus now of research, but in my view, this should be making us think even harder about how do we prevent TB in the first place. Next slide. Now, most of the data are from adults, but these are some data from children, both from South Africa, also some adolescent data from South Africa and data from the Gambia. And what the data basically shows in following up children who have had TB, that if they've had TB, they have more likely to have lower nutrition, which is what we expect, wheeze, poorer lung function. Similarly, adolescents, abnormal lung function at the end of TB treatment, reduced exercise tolerance. Similarly for the Gambia. So even young children don't get full recovery from TB. Again, another reason to prevent. Next slide. So if I can just finish today's talk on focusing on TB. Major problem globally. Over 2 million children and adolescents develop TB each year. And the largest proportion in young children, the next largest proportion older adolescents, 15 to 19. High burden of disease in older adolescents. And remember that they often transmit disease. Unlike young children, it's an issue of morbidity and mortality. Older adolescents commonly transmit disease as well, so like adults. And there are a large numbers of TB-related deaths, we think, every year in children. Most of them are children who have not ever been detected or treated. I've just already mentioned that there's a particular challenge of TB in the older adolescents and that it's commonly transmissible. Next. So for Indonesia, which has the second highest number of TB cases globally after India, this is the data that is reported to the WHO. Now, we know that there are fewer cases notified compared to what we expect, partly because there are people with TB in the community who are not yet sick, who may not have symptoms, but also partly because even in child TB, not every child who is treated for TB is notified to the program. And that is something that we really could improve on. We need for programs to know what is the full burden of TB. It is the programs that organise, procure the drugs to treat TB. They need to know how much drugs we need to be able to treat all the TB. It is the programs that organise preventive activities. So we have to improve also, not just on detection, but also on notification. But one of the really big challenges, I think, for Indonesia is that even though it's been universal recommendation for a long time that we should give TPT to young child contacts of bacteriologically positive TB cases, it's estimated in Indonesia that the coverage of that is less than 2%. And so that's something that is huge in terms of what we can achieve by improving and for prevention. Next slide. So the case and treatment gaps and the prevention gaps are global. Globally, the biggest gap in terms of detecting TB and treating TB is in children more than adults, and amongst children, it's children under 5. And we recognize why, because they often need a clinical diagnosis. It's hard to get bacteriological confirmation, and children under 5 often present with respiratory disease, malnutrition. So you have to find the TB cases amongst all those other sick children. But this is also disappointing, is the prevention gap, in that many children who should be receiving TPT don't. Next slide. The risks we understand well. We understand that if you're infected, your risk of developing disease is age-related. If you are under 5, in fact, if you're under 2 and you're infected because you're exposed to TB, your risk of developing disease is actually very high. And that's one of the reasons why we focus on contact screening and TPT. And a lot of this TB is disseminated TB, like TB meningitis, which has a high mortality. And then the risk starts to go up again in adolescence. Next slide. And as I just said, for severe disease like miliary TB, like TB meningitis, very high risk in the young children. Next slide. But in terms of transmission, in terms of spreading TB in the community, it's not children under 10 who are contributing to that. It's actually the adolescents particularly where that risk goes up. Next slide. So this is the spectrum we have to try and remember. The risk is high in young children, it goes down, it goes up again in adolescents. But what really changes importantly is the clinical presentation. So for young children, most of the children with pulmonary disease have lymph node disease like this, or they may have disseminated disease like this, which is miliary TB. Whereas once you start moving into adolescence, they're more likely to have adult type disease, such as this X-ray, similar to the one that Prof. Finney showed a little bit earlier. BCG has a role in reducing these red bars of disseminated TB. So BCG is important for this group, but it doesn't really work as a vaccine for the rest of the TB. And so what we end up with is that this group often have adult type disease with bacteriological confirmation, but this group, we often have to make a clinical diagnosis because bacteriological confirmation is not so common. Next slide. And the diagnosis, the clinical diagnosis, you don't need to review this, you understand, but the chest X-ray is actually a really critical part of the diagnosis. I'll spend a bit more time on that next. Now, we talk more and more about the development of rapid diagnostics, and that is important, the development of rapid diagnostics. But this slide is to show you about the rapid development of diagnostics. And the rapid development of diagnostics for child TB happened 140 years ago, and we've really had very little improvement. Now, you saw what happened during COVID in terms of how quickly we got diagnostics. You saw how quickly we got vaccines. And TB is a disease of a vulnerable, poor population, and they do not get the investment in terms of research and development that they deserve. And it's very sad that we still have to keep struggling along with these sorts of diagnostics. Next slide. These are the important issues around TB evaluation. We always think of the age. Obviously, the nutritional status of the child is absolutely critical. I think this weight charts are a very, very important tool that is not used enough. The history of contact, the BCG status, and the risk of other mortalities, morbidities like malnutrition, HIV. Next slide. And we use the diagnostic tests whenever available. And the common one that's recommended now by WHO is the Expert Ultra, because it has a higher sensitivity. And you can use it on sputum, obviously, which you can get by gastric aspirate or nasopharyngeal aspirate, or even swallowed sputum from stool, or lymph node aspirate or CSF. These are the important ones. Next slide. And this is just an illustrative example of the different specimens. This has become quite popular outside of the teaching hospital setting where you can easily collect a stool, but its sensitivity is not as good as gastric aspirate or induced sputum. So it's a convenient sample, but it's not as good in terms of sensitivity as the others. Next slide. And these are other tests that should always be considered. HIV tests for any child with presumptive TB, chest X-ray we use a lot, ultrasound, particularly when we have collections such as pleural or peritoneal effusions. And this test can be quite useful. It's not a test for disease, whether it's a skin test or an IGRA, but if you don't have a contact history, it can be useful to establish infection. Next slide. This is just a recent study that's used a number of these different tests like stool, nasopharyngeal aspirate in children presenting to the primary and secondary care levels, not to the big hospitals, and looking at high-risk groups, often presenting with acute disease such as severe pneumonia. And you can see that in just a large group of children who had severe pneumonia, you can see the settings where the studies were done, who had severe pneumonia, presenting acute severe pneumonia, typical high case fatality rate. There was TB in 7 0.5%. We have to think in children of TB as a cause of acute severe pneumonia. In the group with malnutrition, the yield of TB was even higher. Malnutrition, many children with malnutrition are malnourished because they have TB. And we know that there's a bidirectional relationship. Malnourished children are more at risk of TB, but TB also causes malnutrition. So we should always think of TB in the context of a child with severe malnutrition. And these studies found that the TB diagnosis was actually very common, almost 1 in 5 in children with severe malnutrition in Uganda, Zambia, etc. Next slide, thanks. So what we're left with is we have expert, we have a new rapid diagnostic, but it's only about 60 to 70% just go back, sorry. 60 to 70% as sensitive as culture. And even culture in children is still only up to around 50%. Most of the children still require a clinical diagnosis, which is very different to adults where you'll get a positive result in the majority. So expert ultra is now recommended on a range of specimens, but a negative lab result does not rule out TB. Most children require a clinical diagnosis. Next slide. So to support clinical diagnosis, the union has developed a range of tools that are available to everybody. This is the second edition of the Diagnostic Chest X-ray Atlas. Dr. Finney and I were talking earlier about Professor Robert Gee. He wrote the first atlas, I think, about 20 years ago. So there's now an update, and there's various other online image libraries and online trainings that can be done. So this is all union resources, very much online. Next slide. Next slide, thanks. That's the image library. Next slide. And that's translation to Indonesian, just like you said. So there is a Bahasa version, which is freely available as well. Next slide. So some of the features, TB is not always non-specific. Some of the X-ray features are actually quite specific. This morning we were reviewing a child with a massive mass in the right upper zone, which is probably a tumour. But this type of thing, this is only TB. TB causes these sorts of lymph node enlargement. Next slide. And you can see it often even better in the lateral X-ray. You can see this sort of typical lymph node enlargement. And that is a hallmark of TB. Nothing else really presents like that. Next slide. Or you can get miliary TB. Next slide. Or you can get the typical cavitations of adult type TB. Next slide. So the diagnosis approach, like any sick child, the first question is, does the child require inpatient care? Is the child very sick? Is the child hypoxic? Is the child got respiratory distress? Is the child severely malnourished? Does the child require inpatient care? That's the first question. And then you can do whatever investigations you require as an inpatient. The next is the child at risk for severe disease? So age, malnutrition, HIV. And then you have to start to consider site of disease, age of the child, severity of the disease. Maybe you're going to choose to treat for 4 months or 6 months, and then whether you think the child has drug-susceptible TB or drug-resistant TB. These are the decisions that we have to make. Next slide. And there are more and more treatment decision algorithms being developed. Indonesia has its own pediatric score, and this has been reviewed recently by Dr. Finney, Dr. Triasi, and others from the Indonesian Pediatric Society, but they have their own management decision algorithm that they're developing. This is just one example using all of that information that is in the union desk guide. Next slide. And we also have to so let's just go, no, it's okay. So the other thing that's also important to recognize, I think you all do understand, is that we don't dose by age, but by weight. And for children, the dosage is recommended for young children is higher than adults in terms of range. So it's always important to have clear guidelines as to what dosages you're going to use. Next slide. And we now have available to us child-friendly formulations that are dispersible, where the tablets can be just dropped into water and they disperse and then the child can drink them. So these are, and that's also suitable for the preventive TPT as 3RH. So these are all preferred choices by health workers and families. Next slide. One study that's come out recently, which I don't think it's changed guidelines yet in Indonesia, and maybe it won't, but is the fact that in children with non-severe disease, 4 months of treatment is equivalent to 6 months. So in children under 16 with non-severe TB, those that receive 4 months, so a shorter continuation phase, had equivalent outcomes to those that received the full 6 months. Next slide. Next slide, sorry. And these are the types of TB that we are now starting to treat with just 4 months. So porcibacillary TB, uncomplicated on chest x-ray, and or lymph node TB such as in the neck that is peripheral and isolated. These were the sort of children in the study. And these children will respond well to just 4 months of treatment. Next slide. And these are the results of that particular study, which were published a couple of years ago. There was no difference between the two groups on any of the subgroup analysis, etc. So 4 months, not inferior to 6 months. Next slide. This is a major challenge, tuberculous meningitis. Even this morning we saw quite a lot of, well, I didn't see each child, but I was told there was quite a lot of children in the hospital with TB meningitis. I get a feeling that TB meningitis is quite common in Sumatra in children. And that's a bit of a disaster because it has a high mortality, but even in those children who survive, many of them are left with lifelong disability and very severe disability. Next slide. So now there's work being done to look at whether we can improve outcomes by improving treatment. Some of this work is led by the work done by Prof. Ruslami, who's from Bandung. Some of you will know, and she's a good friend of Dr. Finney's. And what this is based on is the fact that if you use standard treatment, isoniazid or rifampicin, you will get good levels of isoniazid and rifampicin in the blood, and you'll get good levels of isoniazid in the CSF crossing the blood-brain barrier, but you'll get very poor levels of rifampicin in the CSF using rifampicin. And this was published by Fajri Ghaffar, who is from here. So important to recognize. And so Fajri's done very good work with the pharmacokinetics, a pharmacist originally from Sumatra. Anyway, what this is leading to is changes in TB meningitis treatment so that we improve and increase our dosages of rifampicin. Next slide. And so now WHO recommend you can use 6 months to treat TB meningitis, 4 drugs, but importantly, the dosages of rifampicin and isoniazid should be higher than was previously used. And there will be a study coming out next year, the results of the study, a study of 6 months using high-dose rifampicin and levofloxacin, not ethionamide, but levofloxacin as the 4th drug, compared to standard of care. That study results will come out next year. That study's now been completed. So it'll be really useful to see, because I think to get the best outcomes for TB meningitis, it's not the duration of treatment that matters. I think 6 months is fine. We don't need to treat for 12 months. It's what you do in the first few weeks that really matter, particularly in terms of getting high levels in the CSF. And this little study in Malawi and India found that those that had the higher levels with a high dose of rifampicin trended to better developmental outcomes when they were followed up. So I think this is an important area of work. Next slide. For the approach to MDR-TB, we just simply follow if we don't have a result from the child themselves, we often make a decision to treat on the basis of the DST results or the susceptibility of the index case. And so that's often the case. But what we can do now is we can use all oral regimens. We no longer need to use injectables, and which is fantastic because the injectables commonly caused a lot of distress, a lot of time in hospital, and a lot of profound deafness with long-term disability due to deafness and language problems. So this is a definite step forward. The other thing that's happening in terms of the MDR, we're moving from 18, 24-month regimens to 9 to 12-month regimens. And soon, I think, we'll probably be starting to talk about 6-month regimens for drug-resistant TB. It's also becoming much, much cheaper than it used to be. The cost of treating someone for drug-resistant TB is now much cheaper than it was. So all of these are positive. But the challenge for drug-resistant TB is diagnosis. And I think that remains still a specialist area for pediatrics. It's difficult to manage MDR-TB outside specialist centres. Next slide. What is also encouraging, I talked about child-friendly medications before, but we're now getting more and more available child-friendly second-line TB drugs coming online. So you can see there a whole range of dispersible formulations at appropriate dosages to use in children. So that's also useful. Next slide. Prevention is better than cure. So we had update first time really it was published. Suddenly we're moving from the standard of care for 50 years of isoniazid preventive therapy as TPT, 6 to 9 months of daily isoniazid, to a range of different options that are shorter and safer and have better adherence. So they're more likely to complete, probably because they're shorter. And one of them requiring only 12 dosages, weekly rifapentine and isoniazid, 12 dosages compared to 180 dosages for 6 months. So we're starting to move towards, with strong recommendations and high quality of evidence, to shorter TPT. Next slide. The main challenge for TPT, in my view, is to get to the contacts early. We cannot say to a family, a mother, father who has TB, do you have children? Yes, I do. Okay, can you bring them to the hospital because they never come? Or we will come to your household and wait 2 months. If a child who's a contact is going to develop TB, most of them will develop it within 3 months of being exposed. They develop it quite quickly. And that's what this data show. This includes data from around the world, including from Indonesia, from Dr. Triasi's studies. So basically it just shows that if you've been contact, this is the time of index case diagnosis, and this is the time in following up it takes for children to develop TB. And most of the children will develop TB by 3 months following contact. And if you're under 5, it's even quicker, which is no surprise. So the young children particularly can often develop TB quite quickly. So if we're going to do TB contact screening, we need to do it quickly. Next slide. But it's very effective. And this is again a meta-analysis of data from all around the world, from many studies, large number of participants, also put together by Leo Martinez, who's an epidemiologist, originally from Chile, now based in the US. And Leo's put all of this data very helpfully together, and he's looked at the effectiveness of TPT. And what you can see that if there's ever, in children who have been infected, you have 91% protection. That's excellent. 91% protection against developing TB for young children under 5 who have been infected. And even for the older children, adolescents and adults, it's 80%. So it is very effective. And yeah, next slide. And this just shows what I've just said. If you've been infected and you're under 5, the protection, which is less than 1, is very high and highly significant for under 5 for all age groups. This is for those, this is all overall. If you don't have a test for infection, you can see that it's also effective. If there's a test for infection and they're not infected, obviously it's not so effective. Next slide. Now, these are data that for a long time we weren't sure what to do with MDR contacts. These data haven't been published yet, but they will be published in the next month or two. And so these are from 2 studies. One is the VQuin, which studied drug-resistant TB contacts who are adolescents or adults in Vietnam, and gave levofloxacin to some and placebo to the others. And this is the TB CHAMP study, which is under 5 children in South Africa who were contacts of drug-resistant TB contacts. And both studies took exactly the same methodological approach. And what you can find is that levofloxacin is protective. So for those contacts in drug-resistant households who have been exposed, to give them 6 months of levofloxacin was associated with 50% reduction in them developing disease compared to placebo. So there is now evidence. And the nice thing from this study was they were able to compare safety and tolerance of the drugs. And I can tell you that levofloxacin was very, very safe. There was almost no grade 3 or 4 reactions, but it wasn't as well tolerated as placebo. So particularly amongst the adolescents and adults in Vietnam, it wasn't uncommon for them to complain of GI upsets or mild symptoms, but none of the reactions were severe. So we're now moved to a time when we're getting more and more safer, shorter regimens. And I just wanted to highlight as well, we've got drug-resistant contact. These came out just last month, the updated version, and in 2024. And this is also important. Rifapentine, which we can use as weekly TPT, that was not recommended to be used in children under 3 until recently, but those recommendations are changing. So what we're going to be able to do is we're going to be able to use weekly TPT for all ages using the same regimen, and we're going to have dispersible formulations of rifapentine, 150 milligrams, to be able to use for that purpose. So I think that's also going to be a step forward. Next slide. But really the big challenge is implementation. If we sit at the hospital such as here and we invite the families to bring their children along because you've got TB, do you have any children or do you have anyone else in the household? Yes, I do. Is anyone sick? Yes, someone is, but the rest not. Oh, you better bring them to the hospital. Most of the time people won't come. And particularly the ones who won't come are the ones who are well, because people think, well, why should I go to the hospital or take my children to the hospital? They're not sick. Or the ones that the children are going to school or various other things like that. So most of the time they actually don't come. And what we need to try and do now is to move more and more to go to the households. That's actually what we do in Australia as standard of care. We have public health nurses who visit every TB household. They do the TST in the household. They'll often start the TPT in the household. And that'll be done at the household community level. So this study is just what shows common sense, but basically it was a study we were involved in where we did a cluster randomized study. One group was an intervention community arm where community health workers with a nurse went to the household, and that compared to the facility arm where the doctor said, please bring your family. And we compared the two, and what you'll find, next slide, and next one, you'll find that in the intervention arm, there was much higher coverage of screening and much higher completion of TPT. And I know that that is common sense, but at the same time, it's nice to have data that show that it actually does matter. Next slide. This is data from Yogyakarta, recently done by Felicia, a GP who works with the Zero TB project. And what she did was to have a dedicated nurse at the Puskesmas level implement contact screening for bacteriologically confirmed TB index cases using these 3-month regimens, 3RH or 3HP, using close monitoring, treatment adherence, side effects. And this had a high uptake of TPT, almost 80%, and a very high completion rate. So it was achievable in this setting in Yogyakarta. And so, next slide. Thank you. This is work done by Sasi Lestari that is in Papua province. And Sasi's work has been around health system strengthening, basically moving TB services, not just to be centred at the facility in the big hospital in Mimika, but also to move them to the Puskesmas. Next slide. Using the resources that are already available, not introducing any new resources. And what the work that Sasi did was able to show was over time, you increased your TB case finding. And what you can see is most of the increased case finding happened at the Puskesmas level. And that even during COVID, the treatment outcomes were sustained and the treatment detection didn't drop as much as in other parts of Indonesia. Next slide. We do similar work in Papua New Guinea, and really critical to it is the community engagement. Engaging people who are often TB survivors themselves. They're very powerful for education in the community, community health workers, community advisory board, social support. TB is a disease surrounded by psychosocial challenges. And this is something that you have to pay attention to in supporting families to be able to get through that to completion. Next slide. Operational research, huge potential in child TB, child and adolescent TB for operational research. This is just some work we've done with a group. The first, so, yeah, it's okay. So yeah, I think there's great capacity. This is a great opportunity for operational research building. Next slide. And this is just some of the operational research in a setting where we have very, very high levels of drug-resistant TB. Over time, through operational research and improving implementation, is improving the success amongst adults and children with drug-resistant TB. And we see about 300 cases per year to some of the highest levels internationally, recorded internationally. Next slide. So just to finish, why don't we have a TB vaccine? I mean, during COVID, we had a lot of development of vaccines, and people still ask the question, including the Minister of Health from Indonesia was asking, why don't we have a TB vaccine? And I don't think people recognize that maybe the TB is a slightly more complex mycobacteria than a virus, where the antigen that you're trying to challenge may be a single antigen. Here, it's a whole complex array, and we're not really even still sure which ones of those are important. Never mind, next slide. This is how long ago we've had BCG. Professor Calme was one of the, that's his name in the BCG. He was also a founder of the International Union Against TB and Lung Disease. And that is the group that is having a conference in Bali in November. So this is a group that's been going for a very long time. There's a lack of gender balance there in that photo back in the 1920s, but I think things have improved since then. Next slide. And so just next slide, thanks. So there's a lot of candidates now in the TB vaccine pipeline. And the most promising one is the M72. The M72 has shown given to adults and adolescents that in a phase 2B trial, that it may have 50% efficacy against disease, which would be fantastic. Next slide. So next slide, sorry. So I think what we have is a BCG that does its work early on in reducing disseminated disease. What we actually really need is a new vaccine that we can give to early adolescents to protect against that rise in TB cases. That will also protect against the transmission of TB in the community. And if we can protect against the transmission of TB in the community, we've prevented TB in children. Next slide. So this is where we're at the moment. Finally, we're getting some investment into vaccines, and hopefully prevention with vaccines will be one really important tool for the future. And some of this work is now being done in Indonesia, it's being done in Jakarta, and it's being done in Bandung. And so I think as part of 6 other countries around the world doing this vaccine work. Next slide. So thanks very much for your time. I want to acknowledge my colleagues, such as Dr. Rina Triasi, Dr. Sasi Lestari. Some of their work I referred to. I've had the great pleasure of spending time in Dr. Sarjito Hospital and UGM, Dr. Cipto at Universitas Indonesia. I won't remember in Pajajaran in Bandung or Surabaya the names of the hospitals, and now here. But what I see amongst the pediatric community is a great enthusiasm now and an awareness of the importance of child lung health, and particularly child TB. And all I would say to finish is that there's a lot, even though pediatrics isn't given the attention for TB as adult TB, we actually have a really important role to play. We can still contribute a hell of a lot to TB control, and opportunities for prevention, we're leading in that regard as well. So thanks very much, and thanks for listening.
Thank you for amazing lecture, Prof. There's a lot of update here in pneumonia and tuberculosis. This interesting lecture. So I would like to invite all the attendee. Is there any? We move to the question and answers session. Yes, please.
So first thing first, I hope you have a great lunch that we never asked for but are blessed with. And I said earlier that the yesterday is pouring, but today is a very special day because we have a Professor Stephen Graham here. I was so touched by your words that the children do not have the voice, so pediatricians represent the voice for them. And so we are looking forward to seeing the advocacy in the future for, especially for whom were left behind. And my question is that we face the same issues that the newest outbreak during COVID area. I'm sorry, during COVID era since 2020 or 2021. For instance, we have a diphtheria pertussis. So here we have finding the new cases of pertussis since 2021, I guess, 2022, and it's even malignant, Professor. This particular patients required the ventilator, the intensive care unit, and they ended up passing away. So my question is, what are we gonna do next for this newest and latest outbreak due to the COVID eras before? Thank you, sir.
Yeah, thanks very much. It's a challenging question. It's an important area to highlight. Dr. Nina Putri, who I think some of you know from Jakarta, infectious disease, as part of her PhD, she's looking at issues around COVID. And one of the things that she wants to look at is what actually happened. So I think getting data is important to show that measles went up, to show that diphtheria went up. These are really important things. I know it's already in the past, but it's really important to show that. So, because every time we get these surges in disease, Our hospitals get overloaded. It's very expensive, and yet so much of this is preventable. So one area that I guess our group in Melbourne are very involved in, but also I think more globally, is the whole idea of vaccine hesitancy. And I think there are always going to be in every community people who are reluctant for their children to be vaccinated. And during COVID, for reasons we don't understand, I think that group maybe increased to some degree. There was fear. And then also at the same time, because of COVID, the health workers were distracted. So those that used to provide immunisation had to look after COVID. So there was two things going on at the same time. So what we've got is lessons learned. How can we improve or reduce vaccine hesitancy or that distraction from health services that happened during COVID? I think that's something we don't really know whether we've learned from this recent episode until we have the next pandemic. That's sadly the situation, because we would like to think that when we have the next pandemic, we will do better. We will do better in the way that we respond to the pandemic so it doesn't have so many consequences on children. Let's face it, children didn't suffer too much from COVID, but they suffered the consequences of all of the things that went with the pandemic. And that's something that we have to be very mindful of and work with. So I don't have an easy answer, but I think getting data, thinking it through, etc., is important. I think if I was in public health at a national level and had a pandemic, I'd be trying to deal with the pandemic, but I'd also be trying to protect the things that we already have that are good. And I don't think we did that very well during COVID.
Thank you, Prof. I think you get the answer. Yes, please.
Thanks, Professor. My name is Bobby. I have the two questions. The first about the antibiotic resistance. How does antibiotic resistance affect the management of community-acquired pneumonia compared to hospital-acquired pneumonia? The second about the microbiome. What does the lung microbiome? Professor, thanks.
So thank you. To answer the first, or not to answer it, the second question, I actually don't know. I think you're probably right. Microbiome of the lungs is important, but I'm not familiar with the data. I know, for example, that one of my colleagues in Melbourne has been looking at microbiomes in children with cystic fibrosis, which is a particular high-risk group for severe infections. There's some interesting findings, but I'm not really sure that we know the answer to your question. I don't know anyway, so I won't try and answer it. I sort of know a little bit more about the gut microbiome. I think we know more about the gut microbiome than we know about the respiratory microbiome. But the first question was more related to antibiotic resistance. There's no question that community-acquired pneumonia, the bacteria is more like, if it's due to bacteria, most of it's viral, but let's say bacterial community-acquired pneumonia, it's more likely that that bacteria is susceptible to antibiotics than hospital-acquired pneumonia. We all know that hospital-acquired pneumonia has very, very high levels of drug resistance because of the pathogens in our ICUs and things. But increasingly, community-acquired pneumonia is associated with resistance as well. What do we know about antibiotic usage, like in settings? Well, I think we know more and more. I think we know that if people are more evidence-based with their use of antibiotics, they follow recommendations. So in other words, they don't overuse antibiotics. What happens is antibiotic resistance in the community starts to drop. So it is driven by the use of antibiotics, not just in the human industry, but also in the agricultural industry as well. Giving antibiotics to animals like chickens or cattle to improve productivity. So what drives community antibiotic resistance is use of antibiotics in the community. What drives hospital-acquired pneumonia is the fact that almost every, in an ICU, they're all getting very broad-spectrum antibiotics. It was interesting in this research that was PhD work of, some of you may know Dr. Inda Kartika, who's also known as Ita, now did her PhD on ICU in Dr. Sajito Hospital, but now a cardiologist. Her work showed that if you introduce antibiotic stewardship and guidelines and you stick to them so that they had less antibiotic usage in the ICU, they had no impact on mortality, they had shorter time in ICU, and they had less cost. And the similar work's been done in newborn care by Dr. Huang Tran in Da Nang Hospital, where introducing newborn care antibiotic guidelines, where before 70% of newborns got antibiotics, and when she changed, it went down to 15 to 20%, there was actually better outcomes in the newborn care. You would think, oh, maybe there's going to be more deaths, but there actually wasn't. And so there is evidence, even in those really high-risk settings, that you can actually reduce antibiotic usage, reduce drug resistance, and still maintain outcomes. So, yeah, but changing practice, as you know, is very, very challenging.
Yang di sini dulu kali ya.
Excuse me, Ricky, can we ask the question?
Okay, please, Dr. Yusri Diane, our gastroenterologist consultant. Yes.
Yeah, the Honorable Professor Stephen Graham, we already know that the elimination of tuberculosis disease from the face of the earth is a significant challenge. So it is difficult to treat tuberculosis in children, especially if the children suffer of liver function disorder when they receive the tuberculosis drug. According to your experience, which is actually the most toxic if we compare isoniazid, rifampicin, ethambutol, or pyrazinamide? This is the first question. The second, beside we change the tuberculosis drug to ethambutol or streptomycin or levofloxacin, what kind of another drug we can give to the children suffer of liver disorder because of drug of tuberculosis? And the third, my question, if did you have experience for prophylactic tuberculosis in children suffer of meningitis tuberculosis but suffer for liver function? Is it have you ever seen the severe liver function disorder in the patient if we still continue give a tuberculosis drug in this patient, because it's important for treat the disease? Thank you.
Thanks very much. So important question is, I think this is all focused around the potential of hepatotoxicity in the drugs, and which we recognize, and it's reality for isoniazid, rifampicin, and pyrazinamide. Perhaps the most likely is pyrazinamide, but I think it's difficult to know. We use isoniazid and rifampicin more commonly because we often use them also as TPT. But my experience is that children and adolescents, particularly children, tolerate the TB drugs very, very well. And I personally have had any child I can remember who has had severe hepatotoxicity. And that's whether they've been treated for TB or TPT with isoniazid or combination of isoniazid or rifampicin. Now, one of the things that we know is that if you put a child on isoniazid, 20% of them, their liver function tests will increase. But that doesn't mean that that child is going to develop hepatotoxicity. So in my practice, I don't even measure their LFTs when I start treatment. And in fact, I don't use it in follow-up unless they're becoming symptomatic. But I think the group that you're talking about are children who already have underlying liver disease. And if you have underlying liver disease, clearly you have to be very cautious about using these drugs. Now, underlying liver disease is not nearly as common in children as it is in adults. One of the reasons I think that in my country, children tolerate these drugs better than adults is because a lot of adults drink too much alcohol. That's probably one reason, and because they're older and they're more likely to have a higher prevalence of hepatitis B, hepatitis C, chronic hepatitis, etc. Children in our setting are protected against hepatitis B. They're not high risk for hepatitis C. They're not drinking alcohol. They don't have a lot of the risk factors for... Yeah. So this is the reason why I think we often don't see it very commonly. Levofloxacin, ethambutol are not drugs that cause liver toxicity in my experience. Ethambutol certainly not, levofloxacin either, but ethambutol is not a particularly good TB drug. It's used as a fourth drug in people with high loads of bacilli to protect against resistance, but it's not a particularly effective TB drug. So I think when you have children with liver disease and you have to treat them for TB, I would be referring to someone like you as the gastroenterologist and saying, well, let's consider which drugs we can use where it's safe, and we would be monitoring liver function tests on a case-by-case basis. So that's my simple answer. I'm trying to answer from the global perspective. Thank you.
Thank you very much indeed, Professor Stephen Graham.
Thank you, Prof. Maybe, yes, the question for our medical students. What grade?
Yeah, my name is Isa. I'm a co-assistant doctor, or in short, co-as here in RSUP Dr. Djamil Hospital. And thank you for the presentation. It was a very amazing and informative one. So as you already explained it from the beginning, that that when a child underwent a serious lung damage when they're like a kid, it would grow like the probability of a lifelong damage of the lung. And I would like to ask if there is, or was it irreversible, or is it completely irreversible, because that's what you undergo yourself, that's your personal experience for this. So as a future general doctor, I would like to, I understand that my main job is to do like promotive and preventive, and my question is low-key referring to rehabilitative, but I would like to ask if there is a rehabilitative method that we could do as a doctor if the patient already had lung damage when they're a kid, or maybe there's a personal method that you already did in the past.
Fantastic question. I think the short answer is I'm not sure, and nobody is very sure. I think what we're trying to understand and learn from is the adult physicians who look after chronic obstructive pulmonary disease. But the pattern is a little bit different. It's a restrictive more than obstructive. And I'm not sure that things like inhaled steroids or, I mean, you don't want to be giving systemic steroids. You might be worth trying inhaled steroids, for example. I know that there's a group developing drugs in Melbourne that have come up with a new treatment that's been published that might have a benefit because it reduces the immunoinflammatory effects. And that's what you're really trying to do, because a lot of what TB does when it does damage, by the time these people are cured, they don't have TB in their body anymore. But what they have is the immune inflammatory effects of the TB disease. And that's what you're trying to dampen down. So I think it's an area for research, really, to be honest. I think for children with chronic lung disease, we always try bronchodilators. We try or preventers like Symbicort, these sorts of things. For asthmatics, I think it's a little bit easier. For these type of things, I'm not so sure.
Okay, do you get the idea or contra comment, please? Yes.
Thank you for the answer. Maybe there's a follow-up question if
Yes.
you may ask. So yeah, there's like another thing like anti-inflammatory that we could do to reduce the inflammation. But if there's like an education or counseling that I could give to the patient, like maybe you should swim or maybe you should do a light exercise, like things like that I could do as a general practitioner, like the education itself. Maybe if in the future I work in Puskesmas or something.
I think you're right. I think that's what GPs would do, and I think they're right in saying that. I think we understand that first they should stop smoking if they're smoking. Second, they should avoid exposure to smoke if they can. But the others, we do know that keeping fit, keeping active, keeping exercise preserves your lung function than if you don't. So we know that. And so we know that swimming, we know that exercise can certainly benefit. So I think, and it has benefits that are beyond respiratory function as well. It has cardiovascular benefits. It has many other benefits, well-being, etc. So I think it's good advice.
Okay, that's a good question. Another question from medical student? Oh, yes. Oh, residents. Yes.
Okay, thank you, Prof, for the opportunity to ask you. I want to ask you, you said that the most commonly cause of bronchopneumonia was RSV. So could you give us some advice to differentiate between the bacterial and viral infection?
Yeah.
And the second one, Prof, I want to ask you about the definition of chronic lung disease. You said that chronic lung disease, but I look for the definition for the chronic lung disease, but I could not find any references about that in child patient. Thank you.
Yeah, fantastic questions. I think chronic lung disease definition, as far as I know, is very vague. I think we just start calling somebody chronic when they have persistent symptoms that are not responding, or persistent or recurrent symptoms that are not responding very well to whatever treatment we try. So it's very vague. So, but that's okay. I mean, I think we do recognize the difference between acute and chronic, and that they often require different management. So in terms of how do you distinguish between viral and bacterial? Well, that question's been going around for a very, very long time. And I still don't think we can do that completely accurately. It would be nice, wouldn't it, to have a little pinprick test of the blood that says this one with respiratory distress is bacterial and that one is viral. And that way we could get our management correct right from the beginning. But that's not available. But one of the characteristics of RSV is that it's often infants and it's often associated with wheeze. Now, that's bronchiolitis, which is one form of lower respiratory tract infection. But what I've noticed is, having worked in many different settings, in Australia, the wheezing, kids with bronchiolitis and wheeze, they're often wheezing, they're breathing hard, but they actually don't look sick. They're looking around, they're still feeding, they're interested in what's going on, they don't look that sick. They may have a fever, they're coughing, sometimes their respiratory distress is up and down. It's and we even have and they're often well nourished. We even have an expression in Australia. We call them the fat happy wheezer. And that is an expression of a child with a viral infection, because they don't look that sick, they don't look that unhappy, and they're often well nourished. Whereas bacterial pneumonia is more of a risk for the undernourished child. They often look sick because they've got a bacterial infection, you know, and how do you differentiate between looking sick and not looking sick? Well, that's what we as pediatricians try and do. But bacterial, you know, they might be more lethargic and etc. So that's probably one thing. But people also use biomarkers like CRP and procalcitonin. But again, these are blood tests that are often readily available. I don't think white cell count is a particularly good one. And even chest X-ray there's overlap between the changes of viral and bacterial. So yeah, I think sometimes it's really clear to me this child may have viral, probably viral. This one's clearly needs antibiotics, but there's a lot of grey area in between. And so I haven't answered your question, but I've just tried.
Thank you, Prof.
Okay, thank you. Any, yes, please.
Thank you, Professor Stephen. Continuing the previous question, I really interested about RSV vaccination to prevent the viral pneumonia. As we know, the RSV is a pathogen that commonest causing the child pneumonia. How about the using this vaccination in other country? In your presentation, that the prophylaxis can by giving the maternal vaccination and using the long-acting monoclonal antibody. How about in other country, particularly in low-income country? Thank you, Prof.
Yeah, great question. And there was a recent opinion piece about this in one of the Lancet journals, that we're going to have to do something about this, because at the moment, but just remember the studies that I showed, one of them was published last year, one of them was published this year. So we're only just starting to get the evidence. And there are a number of questions. The cost. Is, let's say, the Minister of Health of Indonesia going to say, oh, no problem, let's invest in this intervention? Not until probably the cost starts to come down. So that's always an issue. But even the availability, the production of these new tools, I think we're still waiting for them to be built up to scale. At the moment, they're research tools. So in Australia, we still, what they did in Spain, with that, in that whole province, or that area, that they're now considering that whether we might try and do that in some states of Australia next year before the winter. But I'm not sure it's even been decided yet. So it's going to take time. It's going to take a few years. But your point's a very, very good one. But the other challenge we've got for somewhere like Indonesia is that RSV epidemiology is very different here compared to somewhere like northern Spain or southern Australia, because you tend to have RSV that goes on, grumbles on through the whole year in tropical countries. You don't have the clear winter spike. So these things don't last forever. When you give it, all you're trying to do is protect that baby in the first 6 months of life. And so if you've got something that can protect them then you're protected against most RSV. But the problem you've got here is that, well, when do we do it? Do we do it every time a child is born, or do we do it in a particular time of year, or how do we do it? You know, that's going to be a challenge, because that work in Spain, or similarly, if they introduce it in Australia next year, they'll do it all just before winter, bang, and then cover everybody, and then wait for the next winter, maybe. And so this is what goes on. What's happening also is that we recognize, just like the pneumococcal conjugate vaccine, the use of pneumococcal conjugate vaccine reduced carriage in children of pneumococcus. That protected old people against pneumonia. So that was a benefit. And then now in many countries, they actually immunize old people against pneumococcus. What they've realized is that RSV is actually also a major cause of respiratory disease in old people. I mean, particularly people over 70. So it is not surprising, yet little kids and old people, they have similar problems. Their immune systems are not that strong. And so one of the things that is also being looked at, particularly in the US and other places, is the use of modalities like this to protect old people against RSV as well. But so it's a bit like watch this space. I think it's going to take time, but it's going to take advocacy. Going back to that issue of advocacy and data. If we can get more data, for example, from this hospital, how much of the child respiratory admissions are associated with RSV, that would be really useful, for example.
Okay, thank you. Any other questions? Maybe the last question from our Zoom. Next question, maybe. If the patient with baby with the congenital TB, should we check for the HIV status, even though the mother have been checked and it is negative of HIV?
Yeah, I think a baby that has congenital TB, that's a rare situation. If the mother doesn't have HIV, certainly the baby doesn't have HIV. So if I tested the mother and I knew she was not HIV infected, I would not think about HIV for the baby. The major risk for congenital TB is if the mother has disseminated TB or genitourinary TB. Sometimes both of those can be difficult to diagnose, but they're the main risks. But having said that, we recently saw a child in Dr. Sarjito Hospital who presented with PCP. And so this is a child they were treating. I said, I think we probably should do a HIV test. I think this child has PCP. They did a HIV test. It was positive for the child and we treated. They went back to the records of the mother, and when she had a HIV test 3 months before delivery, she was negative. So, and now she's positive. So what you have to recognize sometimes, and I know it's unusual, that when you first do a HIV test on somebody who's only just been infected within the last month or two, it still may be negative. You have to wait if it's an antibody test. And that's probably what happened in her situation. So, but I still think it's very unusual. Congenital TB is quite rare. I'm sure if the mother's HIV infected, it increases the risk because it increases the risk of disseminated TB. But I think if the mother's not HIV positive, I don't think I'd be worrying about the baby.
Okay, thank you. One more question.
TPT for the RTB contact, you said that only levofloxacin. How about the ethambutol? Because in our new guideline, the adult TB contact will add with ethambutol.
Okay. It's a good question. I mean, I think the reason why you had ethambutol was because some of the early work that was done, such as in South Africa, and some of the first evidence that showed that TPT for drug-resistant TB contacts might be effective, that used 6 months of levofloxacin with ethambutol. And so therefore, quite rightly, you decided to use the same. But when you think about it, ethambutol doesn't really make a lot of sense as a preventive treatment. it's not really a strong bactericidal drug. It's bacteriostatic. It's used to protect against the development of drug-resistant TB in adults who have a lot of have cavities and lots of bugs. So it's it's bacteriostatic. So it sort of tries to keep things calm and controlled while the other drugs actually do the damage and kill the bug. So it's not a strong, I wouldn't see it would add very much.
Do you experience about the allergy to levofloxacin?
I haven't seen allergy to levofloxacin, but I haven't seen it, but I'm hearing about it. No, sorry, to rifapentine, sorry, not to levofloxacin. In the work that we're doing in southern Vietnam, it seems like rifapentine, which we're using as TPT, seems to be associated with hypersensitivity reactions. Not something that we've seen in other parts of the world so much, but it seems to be a problem in southern Vietnam. So we'll wait and see what the study shows. But hypersensitivity reaction, not really for levofloxacin. Maybe you have different experience. So, yeah.
Okay. I think that's complete explanation.
I had one question. Everywhere you go in Indonesia, you have to answer the question, what are you eating and how do you like the food? It goes back to your question. So now I've been to a number of different places.
Yes.
Yeah. And for example, in Jogja, everyone wants to talk about gudeg. But I've always said, I think the best food in Indonesia is in Sumatra. Okay? So I'm in Sumatra, that's okay. So I think it was one of the professors earlier said, you must go to Medan to have the food. So I'm still confused. Is the food better in Medan or is it better in Padang? Thank you for that clarity.
Thank you. So we are very thankful for this today's webinar. This is so amazing lecture with fruitful discussion with fellow doctors, consultant, residents, and medical students. It is an interesting lecture, so then amazing and great question from attendance. For the last, maybe we ask Prof. Yeah, maybe closing statement, or you have a message for us?
No, I don't have any more messages. I'm sorry. But thanks for the discussion. I appreciate the fact that people were asking questions and were able to have some discussion, because sometimes you feel like you're just standing here trying to deliver things that you probably already know. And I appreciate the fact of the interaction. And I hope that the interactions between our group here and our groups in Melbourne and our colleagues in other parts of Indonesia can only grow and strengthen, because I think we're going to do much better as a team than as individual siloed working groups in academic institutions, etc. We have to all sort of come together to get the best outcome for the kids in Indonesia. And certainly you talked about opportunities, Finney, for example, for postgraduate training and Melbourne and these sorts of things. These are something that we all are very keen to try to support and enable. So thank you.
Thank you very much. And now we've come to the end of this webinar for this meeting, and the end of this webinar. So I put the mic to the Master of Ceremony.
Thank you, Doctor. What a wonderful discussion in our webinar today. Give an applause to our discussion. To complete the Professor Steve visiting, we have a plaque from Medical Faculty of Andalas University as our gratitude for your visiting here, Professor. Please, Dr. Vini and Prof. Steve to take a place. I think in hold on, ma'am. Okay. And the next souvenir. Please, Dr. Rahmi, come join us.
sees my own silhouette. I'm getting stronger, step by step. The clock is ticking, but there's no time for regrets. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. We are heroes tonight. We will fly above the sky. We are heroes tonight. Yeah. We are heroes tonight. We will fly above the sky. We are heroes tonight. Feel like a dynamite, ready to explode right up in the sky. I need you to listen, I need you to hear, and don't show any fear. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul. We are heroes tonight. We will fly above the sky. We are heroes tonight. Yeah. We are heroes tonight. We will fly above the sky. We are heroes tonight. I've been flying from town to town, from London to Taiwan. I've been all around the globe, trying to protect your soul.
close till I get up.